CME. We welcome you on behalf of AOGS, Ahmedabad Obstetric Society and ART Clinics. Thank you.
On behalf of AOGS, I would like to invite all of you on this very interesting CME that is on IVF related talks. And without wasting much of time, I would request Dr. Munjal to start the session. Thank you.
Our today's chairpersons, to begin with, Dr. Kamini Patel, madam. She is IVF consultant, obstetrician, gynecologist working at Maninagar in Vani IVF, and she has now recently joined SIMS as well. We would like to invite our second chairperson, Dr. Nisarg Dharaiya, owner and director of SNE Hospital. He is also an IVF consultant and a gynecologist as well. Dr. Azadeh Patel, consultant ART Clinics. We welcome you all the three esteemed chairpersons to chair the sessions of the three talks for today's CME. I would like to invite Anushriban for proceeding with lamp lighting. Thank you.
A very warm welcome to once again. Light is a symbol of brightness and prosperity, as sunlight expels the darkness and bring blessings, hope and happiness in our life to make this evening a blessed one by seeking the choicest blessings from Goddess Saraswati. I invite members of Obstetrics and Gynecological Society, Mr. Dr. Jagnesh Deliwala, President of AOGS, Dr. Munjal, Secretary of AOGS, Dr. Kamini Patel, Dr. Nisarg Dharaiya, Professor Dr. Human Fatemi, Group Medical Director, Mr. Ibrahim Elkhatib, Chief Embryologist, Dr. Gurpreet Singh Kalra, Medical Director India, Mr. Vinesh Gadia, India CEO, Dr. Azadeh Patel and Dr. Vivek Kakkar, Consultants of Ahmedabad Art Fertility Clinics, Mr. Jayesh Morwedia, Vice President Operations, and Mr. Bharat Vyas, Executive Vice President. For the lamp light. I would now like to invite Dr. Kamini Patel to commence the session. Thank you.
I have a privilege to introduce Dr. Gurpreet Singh Kalra. He has joined ART Fertility Clinics India and he is a medical director from August 2021. Prior to this, he was working as a clinical director and consultant, reproductive medicine and surgery at Wales, UK, where he is specialist registration as a consultant in UK, Norway. He has also contributed and being an honorary academic lecturer at Bristol, University of Bristol. He is a member of a Q community, a platform for quality improvement in NHS, and a fellow of Faculty of Medical Leadership and Management UK. Dr. Kalra has developed his career in women's health and reproductive medicine and surgery over the last 30 years, working in Europe, a visionary and a strategic clinical leader with commitment to patient safety, quality, outcomes, improvement in the healthcare. A passionate medical engagement expert with excellent communication skills to interpret patients' and clinicians' need. And I think ART Clinics of India would be privileged to have you. And he is going to speak to us today on evidence-based psychosocial care in medically assisted reproduction. Dr. Gurpreet.
Thank you for having me here, chairs. Thanks for very kind introduction. As you can see, my topic of talk today is psychosocial care, impact of psychosocial issues in women and couples who are going through childlessness, unwilling childlessness, and infertility or difficulty in getting pregnant. And I think it's fair to assume that most of you here are one way or the other involved in managing patients who are exposed to childlessness, and some of you are dealing with IVF treatments. And I'm sure most of you do know that infertility as well as IVF treatments come with a heavy psychological burden. These couples, these women, these men we treat, they are going through something we don't see. It's not visible. And if we know what's happening in their lives, what they're feeling, it helps. And not only it helps, but it also improves the outcomes. So my objective is to share with you how much it affects them, how does it affect them, and what is the evidence. Right, so, again, this is quite a familiar statement from World Health Organization stating that health is a complete physical, mental, and social well-being. That's the state of health. It involves anatomical, physiological, and mental health. And then when you're providing care for somebody with a medical condition, providing adequate care to address them all the issues, not only the disease in question. So there is more to it. Showing you this study here from 2008, and it's looking at, what's the prevalence of psychiatric disorders in infertile women and men undergoing in vitro fertilization, just in vitro fertilization. And I think the conclusion is quite telling. It states that the study suggests that mood disorders, and in particular major depression, so that's quite a severe state of not feeling good mentally. So mood disorders, not only mood disorders, but major depression are common in infertile women and men undergoing IVF treatments. And what's more telling is that majority of subjects with psychiatric disorders or these conditions are not diagnosed and not treated. And there is this study then talking about what are the predictors of getting psychiatric or mental health issues undergoing IVF treatment. And it says that a negative pregnancy test in itself is associated with an increased risk of depression in women undergoing IVF treatment. So IVF treatment and then a negative pregnancy test in itself puts them at high risk of having mental health issues. And this study is a very interesting study by Jackie Bovan from Cardiff, where I've been working for the last 10 years. Jackie Bovan is a professor of psychology in School of Psychology in Cardiff University, and what she did in this study was she assessed the state of mind of these women going through IVF treatment, and she she assessed them daily for 7 days, the last 7 days of stimulation, the last 7 days before pregnancy test, and 4 days after that. If you look at the graph with the little crosses, and you see that represents the positive effect and the optimism, how they're compensating, how they're feeling. And this shows us that they're okay in the stimulation phase. That's at the top, they're feeling okay, they are managing, they're coping with it. But as the period before pregnancy test approaches, you see that it starts sort of going down a little. And just before the pregnancy test, not on the day, so these women have negative pregnancy test. So just before the day of pregnancy test, the anxiety is so much that it dips. Their positive effect, the optimism dips a bit. And then as soon as they have a negative pregnancy test, it takes a deep dive. So the optimism they were trying to project, the feeling they were trying to have that everything is going to be well, doesn't last anymore, it dips. And then if you look at the round dots, the graph with the round dots, that's anxiety. The 7 days before, or the last 7 days of stimulation, the anxiety is slowly rising. It rises towards the end of stimulation, and then the 7 days before pregnancy test, the rise is more sharp. Towards the end, as you see, just takes off. The anxiety before the pregnancy test builds up. And right at the day of pregnancy test, on the day of pregnancy test, it's negative. The pregnancy test is negative, and you know, it's a little paradoxical that the anxiety drops. It drops right down, so that, you know, one would assume they're okay now. So the pregnancy test is negative, so what, you know, it's happened, let's live with it. I don't think it's like that. And you'll see in the graph with squares, so that's depression. That's depression. That's depression setting in. And it's simmering underneath. They're sad underneath. They've had difficult time. And the last 7 days of stimulation, it's got a kind of sort of walking along at a level, and then it rises slowly 7 days before pregnancy test. And it starts rising slowly, and then it rises sharp just before the day of pregnancy. Both these things, the anxiety as well as the depression rising, happens before the pregnancy test. That's because of the expectation they have from themselves. The expectation that something is going to go right now. You know, I would say this time as well, add to the sentence, because generally these women have been from place to place, had a number of treatments, lots of disappointments, trauma. So they, you know, then this depression shoots up. Straight after pregnancy test, it goes further up. And it's really taken hold then. It's taken hold on their mental health and state of mind at the time. And it peaks. So anxiety drops, but depression takes its place. And then you say day 3, day 4 goes down a little bit. We don't know after that, but that is telling. That tells us something, what's going on in their minds. We don't see that, you know. It's important to note, we don't see that, and they don't tell us. So what they state here is demands of treatment had a significant emotional impact, especially in the 2-week waiting period before pregnancy test results were given. That period is very tough. And if you guys want to look after your patients, that's the time to get in touch, because you've let them go after the embryo transfer, they've had their treatment, they've gone home. That's the time to intervene. That's the time to contact. Give them a call, whether you give them a call, a doctor giving them a call, a psychologist giving them a call. Give them a call, check how they are. I'm sure they value that. So this is a statement from SART, Society of Assisted Reproductive Technology in the United States. It's the regulator. It collects all the data, and on their website they've got a statement. Now this statement is very, very important to hear. Patients have rated the stress of undergoing IVF as more stressful than, or almost as stressful as, any other major life event, such as death of a family member, divorce, or separation. Now, who would imagine that? You know, who would imagine that? This is what they're feeling, the loss of the baby they never had, the negative pregnancy test they've had, or failed cycle they've had, or being childless, the child they're not having, they so desperately desire. It's a loss like the death of a family member. It's huge. But what helps, I mean, we'll talk more about that. What helps is educating them at the start. If they've been a part of the treatment, if they've been involved in the treatment, if they've been educated what's going to happen, that negative outcome is one of the options, one of the possibilities. You can walk out of this clinic childless. You may not have that pregnancy. It's important to make them aware of that. Manage their expectations early on. We'll talk about that more, but educating them. If they're involved in their treatment, if they understand what is going to happen to me at what stage, what treatment, what medication, what intervention, what procedure I'm going to go through, and somebody holding their hand, a psychological counselor or clinical counselor or the doctor, you know, makes huge difference. Not only they feel better, but if they've been involved and educated about the treatment, there is evidence that the outcomes are better. Why outcomes are better? Understandable, because they're in more control. These women, these men are more empowered. They are less anxious. When they're less anxious, they don't make mistakes with their medication, with their injections, with what time to take those injections, where to go, when to go for their appointment. Things fall in place, and they do the right things, and their outcomes have to be better then. Now, this study from Denmark, Anja Pinborg, looked at what happens to women people who start IVF treatment over the 5 years period. So what they did was, they looked at 1388. So in Denmark, they have public health, not public health, but public infertility treatment program where it is funded by the state. So they're not paying for it. That stress is not there. So one stress is less. So they've had their treatment, and then they've been followed up for 5 years after that to see what's happening with whom out of these. And they also cross-linked the data with their national medical birth registry. So they have a national medical birth registry which they've had for 30 plus years. So they see then which one of these women have had a child in the next 5 years, period, the last 5 years period when they started looking at it. And what they found was that about 70% of these women have had a child of their own. 6% ended up adopting a child. So 30% don't have genetically owned child. 24% have no child after 5 years. So after 5 years, 25%, 24% remain unwillingly childless. This is another study. This is from Heidelberg, Germany. They looked at 10 years follow-up. Not only they looked at what happened to these couples, they also looked at their state of mind, their control of their psychological state, how they're feeling, what their life is like, what all they're doing, different things. Amongst others, what is their current desire for a child? Are they still wanting a child? How is their satisfaction with life, self-esteem, relationship, sexuality, career? How are they doing? What kind of people are they? And how they fared in their lives, okay? And what they saw first was that, okay, similar results to Anya Pinborg's study. They're seeing that 59% at least one genetically related child. So 59% after 10 years have a child of their own. 11% have either adopted or are fostering a child, okay? 30% remain childless. That's 10 years later. 30% remain childless. And what they saw was that there is a significant difference between the lives of people who successfully become parents after IVF and those who have not become parents after IVF treatments. And they see that the childless couples have lower self-esteem. They just feel that they're not good enough. They can't be confident in themselves. When they're amongst people, they feel that they're worth less because there's something deficient in their lives. And somehow they probably blame themselves as well. And not understandable, these can be educated people, professional people, but they feel a loss, a deficit. They have lower self-esteem. With a p-value of 0.01, it's significant. They've also looked at whether they would like to come back for a fertility treatment, and that difference was very significant amongst women. They said, no, I can't, I don't want to. The women who've not had child, 10 years later, after the fertility treatment, they don't want to go through it again. Even men don't want to go through it again. That is also significant. Now, this study looked at psychological and social aspects of pregnancy, childbirth, and early parenting after assisted conception. Now, they've had the child. So what happens if they get the child? Are they okay after that? Has subfertility of being unwillingly childless have left them with any damage psychologically? So this study looked at what happens after they have a child. 28 studies, systematic review. What they found was, I've just summarized and I've just taken out the conclusions here, that anxiety about survival of the baby and early parenting difficulties were higher. So these women continue to be anxious. Sorry. My apologies. So these women continue to be anxious for their child that they have. They are more worried about that child. I might lose it again, And they also have more parenting difficulties. So something has changed in their being, in their mind, in their mental health, in their well-being. They are just kind of not able to cope with difficult situations. And the postnatal self-confidence is lower. We talked about lower self-esteem. Same thing. Even if they have a child, their confidence is lower. So something has changed, even after having a child. That's important to note. So what about women's emotional adjustment to IVF? A systematic review of the previous 25 years of research. This is a study from Holland. And again, I have, instead of going into long detailed sentences, I've just kind of take the crux out of it about how to cope. For those who have not had the child, we looked at the studies, 5 years, 10 years, nearly 25 to 30% will never have a child from those studies. So how do they cope? And what helps? What helps? What helps is, as I said earlier, realistic expectations. Those women who are given realistic expectations, they did better. So all of you who deal with these women, it's very important to know, give them realistic expectations. It may not happen. You may remain childless. Learn to live. learn to or open up to the possibility of having to live without a child. There can be a life without a child. You know, it's not the end of the life. It's sad for now, but it's okay. You know, that is one possibility. Also, it is okay to be the way you are right now. It's not a disorder, it's not a dysfunction, it's not abnormal, it's a normal reaction how you're feeling. So normalizing what they're going through and supporting them and helping them. Now this study is from India, 2021, very recent. It's based on the National Family Health Survey. Apparently there are National Family Health Surveys that happen in India every few years. 1992 till now there have been 4 of them. So they took out the subset of women who were of fertile age and were married. So in the first, second, and third National Family Health Survey, 1992 onwards, as I said, there were about 85,000 women in each. But the last one, the fourth one from 2015-16, there were 499,000 women. The number jumped. So a much more representative sample, I would assume. You know, although population is big, but 500,000 can be a reasonable sample. So they looked at which women, so they looked at women who were having primary infertility. And so the definition of primary infertility was married for 5 years, currently in union or in relationship, still married, never terminated a pregnancy, so never been pregnant, and never had never used contraception, any of the partners. So they were, and again, you know that the medical or clinical diagnosis or the definition of subfertility is having tried for 2 years. But epidemiological is 5 years, therefore 5 years. And this graph, I just put it out of interest, and therefore the definition before that, this looks at the regions and how this primary subfertility has done in different regions in India. And all the regions, the primary subfertile population has increased from the survey before, apart from North. I don't know whether the sample was not representative of what they are doing different, but primary subfertility is on the rise. There are more women who are not having the child they so much desire. But what I want to show actually is this, because it's about the psychosocial impact of being subfertile or having to go through a fertility treatment. And what else is happening? What else are the risk factors? Because that matters. You're looking at primarily subfertile population, and this number is from 2015-16 survey. And you look at this, that there is 44% women. Now again, you know, this study seems to be having a representative sample. 44% women are getting married under the age of 18 years. 33% women have no education. And 38% women are having a poor standard of living. And all these three things are independent risk factors of having a big psychosocial impact, poor mental health, poor health generally. And on top of that, if they're subfertile, having to go through fertility treatment, as we saw, being subfertile and having to go through fertility treatment itself is a significant risk factor. There's a significant population waiting to be in trouble here. Okay, so it's very important to realize this aspect of, you know, you don't see this on anybody's face. We all see these women, these men, and all we need to do is realize, and that's the objective of my talk. It's an extremely important aspect of these patients we treat and what gets ignored. I'm not saying it's necessarily getting ignored. My point is that it isn't that well recognized or not on the top of the agenda if I'm saying that. I'm assuming I'm right to make that statement. So Human Fertilization Embryology Authority from United Kingdom, they've made it as one of their core strategies. In 2017-20 strategy, they've said that we want the clinics to acknowledge how emotionally difficult infertility and treatment can be and act on this. I think this should be true for us too. We want an improvement in the experience of treatment with the minimal emotional harm. You know, the patient experience is important, and I'd like to always say that. When you look at the outcomes, it's unfortunate that the IVF outcomes, KPIs, include a lot of clinical outcomes or embryological or scientific outcomes, but the psychological or psychosocial outcomes is not a part of the KPI. And you know, the outcomes do depend on the experience of these patients. It's important. better support. We want better support for donor conception treatments, because perhaps donor conception treatments are even more bigger setback, you know. And we want support from the clinic after treatment to become the norm. You saw the data after 5 and 10 years. You let them go. It's not ended for them. And you see they've had a child. Congratulations, well done. We gave you the best treatment. It's not the end of it. They're going to be having low self-esteem, low confidence, difficult parenting. All that is happening. You can at least guide them towards the right person to keep having some support. So this is the guideline that came out from ASHRAE in 2015, Routine Psychosocial Care in Infertility and Medical Assisted Reproduction, a guide for fertility staff, very useful read. And I have listed here the grade A evidence conclusions. Now there are more grade A evidence conclusions, but I listed the few I thought were relevant. And the grade A evidence is where there is a meta-analysis or multiple RCTs. So what it concludes with is that it's better to go to a clinic which is dedicated to infertility care, because they're more likely to understand it. What helps is to show understanding and recognize the emotional impact of infertility. It's important to involve both partners, and it's important to involve them in decision making. You know, when you treat them, and if you have given them the understanding of what is going to happen to them, what the treatment is, involve them in it. You know, you make them feel that they are a part of the treatment, they are respected, they are acknowledged, their questions are listened to and answered. That's involving them. But also give them the options. You know, it's not, this can be done, or do nothing. That's always there. You know, and then decide. Just to make them feel empowered. And as I said earlier, there is evidence that outcomes are better if they're involved. Psychosocial care from sensitive and trustworthy staff members. I'd say after that, professionally qualified staff members. We have in our fertility clinics psychological counselors, dedicated psychological counselors, in addition to clinical counselors in every clinic. Doing a brilliant job. They hold the hand of the patient through their treatment. They are their fertility friends. That helps. Don't hurry through the consultation and provide continuity of care. It's important that they see the same person. They find it very difficult to talk. They're not your normal, run-of-the-mill, confident patients. They've been through difficult times, or they're going through difficult times, so they need somebody to talk to, some continuity of care. And your psychological counselor, clinical counselor can give the continuity of care, but also doctor can do that. So that's important. And the provision of opportunities for contact with other patients, that stood out for me. Because if they can talk to somebody who's been through the journey and understands what it means, and if they can talk to that kind of a person who can tell them, yes, I've been through this, I know how you're feeling, that means a lot. That makes a difference. That improves what they're feeling and helps them. And you know, the help is not going to be there and then, it's going to be lasting years, as you know, or as you now know. That's all. Thank you very much. I hope I've managed to give you some food for thought. Thank you very much.
Yes, thank you, Dr. ART practice. We are so engrossed in treating the patients that we forget the psychosocial part. And as you said, they are more comfortable with the psychologist. I would like you to wait here, for a second. May I request Dr. Ajit Bhai, sir, to please present the memento? Thank you so much.
Yes, first of all, I'd like to wish a very good evening to all my teachers, my seniors and my colleagues. Thank you team AOGS and President Dr. Jignesh Daliwala and Secretary Dr. Munjal Pandya to help us organize this CME on a very short notice. I feel privileged and honored to introduce our Group Medical Director, Professor Dr. Human Fatemi. Professor Dr. Human Fatemi has graduated with an MD in year 1999 at Vrije University of Brussels with Magnum Cum Laude. In 2005, he won the Pfizer Educational Grants as the best graduate fellow in gynecology in Brussels, Belgium. In 2008, he was recognized as a subspecialist in reproductive medicine and surgery by ASHRAE, which is European Society of Human Reproduction, and European Board and College of Obstetrics and Gynecology. During his training and later on, also as a consultant, he has performed several studies in the field of gynecology and reproductive medicine and surgery. He has successfully defended his PhD in endocrinology of luteal phase in stimulated and substituted cycles in 2008 at Vrije University of Brussels. Dr. Fatemi is an author of more than 200 internationally peer-reviewed articles and author of several chapters in books. He has given more than 200 invited spoken presentations at international conferences. In 2009, at the age of 35, he received the title of clinical professor from the University of Brussels. So join me in inviting Professor Dr. Human Fatemi.
I was looking at my picture. I look very old in that picture, huh? So we have to change that picture. So I would like to thank the Ahmedabad Society for collaborating and presenting this meeting. It's really always a great pleasure to be back in India. The only problem is if I stay too long in India, I would become fat because I love food, so I have to be very cautious. Now the topic that I'm going to speak about is polycystic ovarian syndrome. And I think, especially in India, you're dealing with a lot of women with PCOS, and it's a challenge for us to treat those women. And you know, we start stimulating them, induction of ovulation. Sometimes it's working, sometimes it's not working. Sometimes we want to have a monofollicular growth, but suddenly we have many or too few, and there is a low response. So the question is, how can we individualize this induction of ovulation for those patients which I consider a difficult kind of patients? Basically, if you look to anovulation and WHO, I think we all agree we have 3 categories, and our main objective is the second category, because the first category is hypo-hypo. It's very easy. You just administer FSH and ACG or LH, and you solve the problem easily. Second are mostly PCO patients, and thirdly are menopausal women, and there is very little that we can do with these patients. So in the second group, basically with the PCO patients, we are dealing mainly with a couple of issues. I mean, anovulation is one of the issues, infertility is one of the issues, but obviously we are also having hyperandrogenism, acne, you have hirsutism. So it's really a systemic disease. It's not only anovulation, it's a bigger problem than simply focusing on anovulation. Now, I don't know if you have followed just before the pandemic in 2018, there was this ESHRE and ASRM coming up with a new guidelines for PCOS, and honestly, I was disappointed because to me as a clinician, there was nothing novel. They invested a lot of money to come up with something new, but if you go back in time, 2003, Amsterdam criteria, 2007, 2008, Rotterdam criteria, 2018, ASRM, ESHRE, but I think we are just back where we were because it's a big question mark, and still we have limited knowledge on how to treat these patients. A point that we all agree is that in different times of life, PCO needs to be addressed on different ways because we are dealing with different problems. It's a systemic disease. It's not a disease that is considered only anovulation and infertility. It's a problem which is considered as a systemic disease. So in fact, in a young age, you have to have a look at the different problematic. At the older age, you have to have a look at a different problematic. So at the young age, we are focusing on disorder of menstruation. We are focusing on hirsutism, contraception, sexual health, and infertility. That's what we are primarily looking at. But in the next phase of life, you know that there could be also pregnancy complications with these women. You know that they have more complications than a non-PCOS patient. Quality of life, type 2 diabetics, if they have insulin resistance. This is also something which needs to be addressed, and we're going to speak about that. Cardiovascular disease, because this is a systemic disease, obviously. Last but not least, cancer risk. You know that the endometrium, if you are not ovulating, is exposed chronically to estradiol. If the endometrium is exposed constantly to estradiol, what will happen? You have endometrial hyperplasia. In the beginning, there is no problem. How do you say in Hindi? Mushkil niya? There is no problem. So the endometrium become hyperplastic. If they bleed, that's okay. But what if this is continuing, and above that, the patient is obese? Because we know fatty tissue has aromatase activity. So they produce estradiol. So you have a double impact on the endometrium. You have estradiol from the fatty tissue, and you have estradiol and no progesterone impregnation. So the endometrium is exposed constantly to estradiol. Hyperplasia, later, possibly cancer. So let's start with the simplest. And don't think that all PCO patients are obese, because that's not true. It's only 40% of all PCO patients who are really overweight. But imagine if they are overweight, what do we have to do? It's very simple. Losing weight. Now you will tell me, of course we know they have to lose weight, and it's difficult to lose weight, but the fact is, you don't need to lose weight, I don't know, 20, 30 kilos. It's just 5 to 10% of the body weight. It's not much. So if you lose 5 to 10% of your body weight, that is more than enough to get everything, to get the engine running again, to ovulate again. So what will happen if you lose weight? Obviously, 5% is enough to start the engine again. Well, this study, first of all, we know if they are obese, you consume much more FSH, and there is a risk of multifollicular growth. If you have 5 to 10%, 55 to 100%, 55 to 100% of patients will resume ovulation within 6 months. And that doesn't stop here. If you take a look, this is a small study, but I think this is a beautiful study. Sometimes these small studies are really to the point, and they describe it beautifully, how we can solve a problem. So if you have a loss of 10 kilos in average, from 67 patients, 60 will resume ovulation again. And 52 of them will become pregnant. And basically, only 18% miscarriage before losing weight, compared to 75% when they were still overweight. So I think it's a clear message. If you have a PCO patient who is overweight, don't tell her you have to lose 20 kilos. No. Just tell her, if you lose 5% of your body weight, that's more than enough. That's what we are looking at. Now, imagine the patient has lost weight, or imagine the patient is not obese, because 60% of these patients are not obese. So what if the patient is not obese? How do we proceed? Let's start with the first line of treatment, clomiphene citrate. What does it do? Obviously, you need to break the circle of anovulation. You need to decrease the estradiol, or the receptors, and you need to increase your FSH level to break the circle of anovulation. And this is exactly what clomiphene citrate would be doing to suppress the estradiol receptors, increase the FSH, and having an ovulation. So when you administer clomiphene citrate, we call it anti-estrogen, but this is wrong. Letrozole is an anti-estrogen. Clomiphene citrate is an estradiol, long-term estradiol receptor blocker. So what happens? Your FSH grows, and there is a chance of ovulation. So in fact, I don't have to tell you, you start 50 to 150 units, day 2, 3, 4, or 5 of cycles, you give it for 5 days. Roy Hamburg published beautiful papers. And something which is interesting is you should do that 3 to 6 cycles maximum. And I will tell you why 3 to 6 cycles maximum. Interestingly, 75% of pregnancies will be achieved during the first 3 induction of ovulation cycles. So most of women will get pregnant within the first 3 cycles. So whatever happens then, you have a plateau and you will have less pregnancies. This is why it doesn't make any sense to continue doing induction of ovulation with such women for 7, 8, 9, 10 months, because the chances are extremely poor, and most of women will do get pregnant during the first 3 months. That's it. Now, clomiphene citrate restores ovulation, not in all patients. You know all better than I do that you administer clomiphene citrate, and you see the patient back after 1 week, 10 days, 2 weeks, nothing is happening. You still have the typical PCO image, and there is no dominant follicle. And of course, when the patients are coming to us, they want to get pregnant yesterday, not today. So we don't want to waste time. The question is it feasible to anticipate which patient will respond to clomiphene citrate, which patient will ovulate with clomiphene citrate, and at the end, which patient will get pregnant with clomiphene citrate? Is there any possibility to anticipate this? And obviously, we know that clomiphene citrate is not the best treatment. In fact, it was approved by FDA in 1954, and I think if you would ask for an approval today, you would not get it because of many side effects of clomiphene citrate. You know, it has a negative, it increases the LH, long-term anti-estradiol effect, thin endometrium, and impact on cervical mucus. And obviously women, opposite to us men, you know, when we age, there is no impact on sperm quality. But women, from the age of 34, 35, there is a rapid decline on fertility. So we don't want to waste time. So is it feasible to anticipate whether the patient is going to respond to clomiphene citrate or not? That's an important question. The answer is clearly yes. This is a paper published by Imani that was approximately 20 years ago from the Netherlands. He works now in the US, but at that time he was working in Utrecht with Bart Fauser. So basically what they say, look, you have to have a look if the patient is a complete amenorrhea or oligomenorrhea. You have a look at the BMI, free androgen index. This is testosterone times 100 divided by sex hormone binding globulin. So this is your free androgen index. And you take the age of the patient. So basically, you have your free androgen index. You calculate the value. And you draw a line whether the patient is oligomenorrheic or amenorrheic. And obviously, you have the body mass index of the patient. You draw a line. You have a chance of ovulation. So you know, based on these variables, if the patient is going to ovulate or not. That's already not bad. Now, you might say, I'm not interested in ovulation. I want to know what's the chance of that patient to conceive in the next 3 to 6 months. The next point is, once you have calculated your chance of ovulation, you draw a line based on the age of the patient, again, oligoamenorrhea, and you have a chance, what is the life birth of that patient in the next few months. So we have some tools to anticipate whether the patient is going to respond to clomiphene citrate, yes or no. Now, I know that in India you are a big fan of aromatase inhibitors. In fact, you're giving it to patients like chocolate. So I know that letrozole and aromatase inhibitors are being used a lot in India since the beginning. Can they be used for induction of ovulation? Yes, of course they can be used. The dose between 2.5 to 5, basically that was one of my first publications almost 20 years ago when I was in Brussels, where we compared letrozole with clomiphene citrate for induction of ovulation, and the answer was yes, and it has no impact on the receptors, and it doesn't have this long half-life time. It means you don't see this thin endometria that we are observing with clomiphene citrate. So it seems to be a good alternative for induction of ovulation. So when it came out, that was 2003, 2004, there was a little bit of concern on safety, because as you know, the indication initially was not for induction of ovulation. It was for women with estradiol receptor positive breast cancer. That was the population where it was meant for. But then Tiboni published a paper that, look, the results seem to be okay, and actually you can use it for induction of ovulation. But Novartis, which is the company producing Femara, letrozole, they said, look, this is the out-of-label use. If you're using this and you have a problem, you hang because it's out of label. And the problem became worse in 2005 when William published this paper at ASRM, and it was a big bang. And I remember when this came out, I received a letter in the university, dear Dr. Fatemi, you are using and publishing papers on letrozole. This is out-of-label use. If something happens, it's your problem. It's not our problem, because they wanted to cover themselves. So what did these studies say? These studies said, look, we have a malformation rate of 4.7%, which is a lot. Among 150 babies born with letrozole, and they compared it with 1.8% database of 36,000 normal deliveries. They said, look, you have 1.8 compared to 4.7. This is almost 3 times the value. So you are doing something wrong. So basically, people will say, look, this is not safe to use letrozole for induction of ovulation. But like many publications, this study should never have been published. The question is, why should it not have been published? Because you cannot compare a database of natural conceptions where patients have no infertility issues, where the average age of the patients is 5 years younger. If you are younger, you have less complications. It's very simple. Where you have more multiples, because you know multiples are linked to more abnormalities. So basically, you have so many variables which are contributing of having more abnormalities. So basically, you are comparing 2 things which should never be compared together. On the other side, this could be used against you if you are using it for induction of ovulation. So what has happened after that? Tulandi from Canada did a study where they compared clomiphene citrate, so the same group, infertile patients, comparing clomiphene citrate with letrozole. Infertile, induction of ovulation. One variable, the drug you are using for induction of ovulation. This is the correct way to do that. And guess what came out? It came out that 400 patients with letrozole, 500 patients with, 500 letrozole, 400 clomid. The abnormality with letrozole was 2.5%. With clomid was 5%, double. That means if you want to register clomid today, you would not be able because the value is double. So after that, we started feeling safe to use letrozole for induction of ovulation. And this is when letrozole became chocolate in India, where everyone started using it, okay? Now, also other studies have looked into that, comparing letrozole with clomiphene citrate and also with gonadotropins. And as you can imagine, it came out that letrozole is doing better. So more and more studies came out, and they all stated the same, that letrozole is doing better than clomiphene citrate for induction of ovulation. This is why we are using it today. And if you compare it with other drugs, we know that letrozole is superior to clomiphene citrate, but we are also look to FSH, because it seems that FSH is even superior to letrozole. But I'm going to come back to that. The next issue, which is to me a very interesting issue, and that will demonstrate to you the weakness of us scientists publishing data. You know, if you go today to ESHRE, or you go to ASRM, you will have a great speaker convincing you that metformin is good for PCOS patients. Now, few months later, you go to another meeting, to ESHRE or ASRM, they will tell you, are you stupid? You are using metformin for PCOS patient. You should not do that because our study failed to demonstrate a benefit. So 1 year it is okay. Next year, it's not okay. Why is that? Why do we have this change is going like the wind from right to left. You all know this is a big question on metformin, yes or no. So how does it come that we are unable to address this question? And you know, I'm going to challenge you. I was hoping that the most recent ESHRE or ASRM definition would have addressed the question of insulin resistance. Do you think they did that? No. So imagine if I want to do a study, metformin to be or not to be, what would I do? I would randomize the patients according to Rotterdam criteria, according to ESHRE or Amsterdam criteria. But do they have a look at insulin resistance? No. So I have no clue if a subgroup of those patients might benefit or no. Maybe they will. But are they all insulin resistant? Of course not. Now you might say, maybe you should stratify according to the weight, how much biryani they have eaten. But the weight is not the only factor of being insulin resistant. You might be a very lean PCO patient and being insulin resistant. And you might be big. I don't want to use the word fat, but you would be big and be not insulin resistant. So before we want to look into the story of metformin, we need to understand how do we define if a patient has insulin resistance or not. Some of you will tell me, okay, let's go for hemoglobin A1C, let's go for HOMA-IR, let's go for glucose challenge test, let's measure the insulin. I'm a very simple physician. I don't like complicated things. You know, there is a great scientist, he said, simplify things as much as you can, but no further than that. And this is what I want to do today. If you have a PCO patient, do you know what is the simplest way to know if she's insulin resistant or not? The simplest way. Sorry? Still, this is complex for me. Easier ways. Sorry? 2 hours? I don't have 2 hours. Easier. Easier. Sorry? That's okay, but still very, very much easier way to do that. So this is the heterogeneity of the studies. With metformin, you see it's hugely heterogeneous. This is why we don't know what to do. Now, did you know that there is a study? They measured the TSH, just the TSH. If you have a PCO patient and you have a TSH of 2 or more, this patient is highly at risk to be insulin resistant. Very simple. I told you I'm a simple person. Very simple. TSH of 2. Now what we do, we measure TSH and the value on our reference is 0.8 to 5, so we are happy. Nope. If you have a TSH of 2.5 or 3 or 3.4, even if your T4 and T3 is normal, this patient, if she has PCOS, has subclinical hypothyroidism. And that patient has high probability of being insulin resistant. Just a simple blood test. Just a simple blood test. If your TSH is elevated, independent of the value of your T4 or T3, that patient is at risk of being insulin resistant. It's a very simple way. It's a very simple tool. Now, you know, we are all also surgeons, so we like to operate. I remember when I was still operating a lot, we were doing a lot of ovarian drillings. The problem is, of course, it works, but then I can tell you, I have seen many women who have had ovarian drilling in the past. They are happy after the drilling because they have a regular cycle, and they think after 1 year that they went back to PCO, and this is why they don't have any period, but it's not. They went to menopause. So it was too much of the egg cooking. And we have to be cautious with the drilling because that will reduce the ovarian reserve, and I think this is something which should be, if possible, avoided. Of course, you can be less aggressive of doing these surgical procedures, but I think this is an option which should be avoided if possible. Now, if you compare clomiphene citrate with FSH, as you can see, with FSH you seem to have better results, pregnancy rate per cycle. And if you put that in a graph, basically you see FSH is really doing better. The only problem with FSH, and I will come back to that point, is a little bit the threshold. You know, you start a certain dose, nothing happens. You increase, nothing happens. You increase, and suddenly you have an explosion, which you don't want. So the question is, how do we address this? Basically, gonadotropins are doing good. The only problem is the multiple pregnancies, as you can see here. And one thing I didn't mention with clomiphene citrate when I told you 3 cycles max, and 75% of women will get pregnant within the first 3 cycles. Why should we not use it more than 3 cycles? Because clomiphene citrate is one of the very few drugs we are using in the field of human reproduction which can increase the risk of ovarian cancer. So this is why we should be extremely cautious and inform the patients correctly that this is one of the few drugs that we are having which can increase the risk of ovarian cancer. So 3 cycles, most patients who get pregnant will get pregnant in the first 3 cycles anyhow. Now coming back to the FSH. So we said you stimulate, nothing happens, increase, 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 explosion. Not good. So what are the different ways of dealing with that? You go with conventional. You start with an atomic bomb, 150, and obviously this patient will have maybe 15, 20 follicles, so there is a risk of multiple pregnancies, which is not good. And I'm not speaking about hyperstimulation, really multiple pregnancies. Or you go with a step down, but it seems not to be really different because in the beginning you recruit the follicles, and once the follicles are gone, they are gone. Even if you do the step down, the follicles are growing because at the end they have no FSH receptors, so you will go with a multiple pregnancy. Or you go with a step up. So you start with, let's say, 50 to 75 units, and in fact, after 1 week, if there is no response, you increase, no response, you increase, no response, you increase. The problem still, you are having 10% of multiple pregnancies, which is still too much. But what is the best way to go ahead is the so-called low-dose step-up. This is very difficult. Also, to me, it's very difficult. Why? Because I'm not a very patient person. You see, if after 1 week nothing is happening, I would say, let's go for it. This is wrong. This is wrong. What is the correct approach is that you start 50 to 75, 2 weeks. 2 weeks. The problem is if the patient is coming after 1 week and nothing is happening, she will be disappointed. So, doctor, you have no clue what you are doing. You gave me all these injections, nothing is happening. But then you have to tell her, look, be patient. Let's continue 1 more week, and if there is no response, then we can step up. After 2 weeks, you do a very low dose step up on a weekly basis, and there you have only 5% multiple pregnancies. And in fact, if you do that, you have 20% pregnancy rate per cycle, and mostly singleton. And that's the primary objective. I mean, you want to have a singleton pregnancy, you just have to be patient with your patient. So this is a very simple tool of treating these patients. Now, what is the dose that usually is used for induction of ovulation? And as you can see, the initiation dose is mostly between 50 and 75 units. And Nibu Anderson published this paper where they look to the volume of the ovary, and they stratify the patients to amenorrhea, oligomenorrhea, and ovulation. And based on that, they calculate with the BMI and the volume of the ovary, which is the best dose for every patient to start a stimulation. Now, imagine you are stimulating a patient with gonadotropins. The first thing that you see with gonadotropins is that after a while, the estradiol levels are going to increase. Now, if estradiol levels increase, there is obviously a risk also of premature ovulation because estradiol is going up. So the next question would be, if you do that and estradiol is going up, is there a need to administer an antagonist to possibly improve the cycle outcome? And the answer is yes. This is a paper we have published with Yanis Kosmas when he was working with us in Brussels. And the answer is yes. So if you use gonadotropins and you have, let's say, 2 follicles, estradiol goes up. If you administer antagonists from a follicular size of 1450 millimeters until you go to 1780 millimeters, you trigger, you significantly improve the outcome. Very simple. Now, this is something which can be added to prevent a premature LH rise. But now, if you go to the second half, so you have done your follicular phase, you're happy, you have 1 or 2 follicles, the patient is ovulating. Let me ask you a question. Do you have to support the luteal phase of an induction ovulation cycle? What do you think? You should ask me the question now, how did you stimulate? Don't tell me yes, because you have to ask, did you use gonadotropins? Did you use clomiphene citrate? Or did you use letrozole? Because when I ask you induction of ovulation, what kind of induction of ovulation? You cannot put all in one basket. Now, if you use induction of ovulation with gonadotropins, absolutely you're right. Yes. Why? Because you have high levels of steroids. Once you ovulate, you have high levels of progesterone. The progesterone creates a negative feedback. Your LH will be suppressed. If your LH is suppressed, your corpora lutea are not producing any progesterone, so you need to support it. Absolute, yes. But what about clomiphene citrate? No. Why? Absolutely. Absolutely. Because if you use clomiphene citrate, what will happen? This is a paper we published with Dimitra Kirou, one of my PhD students in Brussels. We said, look, clomiphene citrate, induction of ovulation, luteal phase support, need or habit. And unfortunately, we love habits. We love giving a lot of medication to patients. But is it always good? Maybe not. So what's happening, clomiphene citrate is indeed increasing the LH. And LH is what is missing in the luteal phase, so you don't need luteal phase support in a patient who has been done an induction of ovulation with clomiphene citrate. So I think we can conclude PCO is a difficult entity. Start with the easiest part. If the patient is obese, 5% body weight loss. That will resume ovulation in most of the patients. If you take a look at FSH, letrozole, and clomiphene citrate, I think we all agree, and it's very clear, letrozole is superior to clomiphene citrate, and FSH is superior to letrozole. The problem is with FSH, you have to be very cautious, because if you give too much, you have the explosion which we don't want to have. You can use the FSH nomogram based on a dose, but most patients between 50 and 75, they would be okay. But please be patient. You have seen 2 weeks, and then slow step up that you're going. Luteal phase support obviously is mandatory if you are having FSH administration. But for clomiphene citrate cycles, there is no need. And if you're using FSH for induction of ovulation, you would add antagonist. Obviously, as you have seen from a meta-analysis by Yanis Kosmas, you significantly improve your outcome. Thank you very much.
Thank you so much, sir. I would like to
We would like to invite our third speaker, Chief Embryologist of ART Fertility Clinic, Mr. Ibrahim, sir. Mr. Ibrahim has completed his bachelor's in Genetic Engineering and Biotechnology. He has done MSc in Healthcare Management and MSc in IVF Biotechnology and Human-Based Research. He has done his thesis on time-lapse monitoring system and pre-implantation embryo development kinetics. He has more than 10 years of experience in the field of embryology and was part of the team that started the first IVI RMA clinic in the Middle East. He has contributed to the several scientific publications in the field of reproductive medicine in time-lapse monitoring, mosaicism, and embryo morphokinetic. We would like to invite him on a topic of PGT-A, and he would be the most appropriate person to give us idea about the PGT-A related technology. Thank you.
Thank you. Thank you. It's a pleasure to be in India. And I know it's almost 10 p.m. now. I promise I'll be fast as long as you support me and support the embryologists, since most of the audience are physicians. So the topic is about PGT-A and mainly about the challenges that is facing or faced us in the PGT-A program. And hopefully by the end of this presentation, we're gonna build a bridge between the physicians and the embryologist in order to show how we need to complement our services in order to get the best outcome. So starting with this picture, which represents our ultimate goal, which is having a successful implantation that will result eventually in a healthy live birth. So despite all the advancement and the knowledge that we have in the field of reproductive medicine in the past 40 years, still the national reports of healthy live birth did not exceed 45%, which shows that there is still a lot to do, that there are many challenges that we need to overcome, and mainly it's the embryo selection criteria for a transfer. So what are these selection criteria? How do we select embryos for a transfer? Most of the clinics are using morphology as the main criteria. So you transfer embryos based on their morphology only. Very few clinics, they combine also morphokinetics, which is mainly some time points for specific divisions. And also few clinics add to that the PGT-A or checking the aneuploidy embryos and transferring them. So I'm gonna ask a question. We have these two embryos, embryo number A and B. Clearly, there is difference in the morphology between these two embryos. So if I may ask, who would transfer embryo A in the room? Dr. Fatemi only? Okay, so, and embryo B? You're gonna transfer B. So, of course, most of the people, I think most of the people will cancel the transfer because they didn't select any, but mainly they would choose A based on morphology. Now, this is a real case that we had. We did PGT-A, and in fact, embryo A was aneuploid embryo, 2 chromosomes were missing, while embryo B was euploid, transferred, and resulted in healthy live birth, which shows that morphology is not always the way to go. And to add, in this study, specifically for the patients that are 38 years old and above, only 20% of excellent quality cleavage stage embryos are euploid. So 80% of these embryos are actually aneuploid embryos. And blastocyst, of course, better, because only 50% of them are aneuploid, so it's almost 50-50 chance of choosing the right embryo. So to simplify, aneuploidy is when we have an error during chromosome segregation. So once whether it was meiosis before, during the maturation of the sperm or oocytes, or during the cell division after fertilization, if we have any error during this separation, this will result in an uneven number. So you can have extra chromosome in one cell or missing chromosome in another. And aneuploidy itself was linked or was We all know that aneuploidy, when we hear the word aneuploidy, we should always relate that to mental retardation, we should relate that to pregnancy loss, we should link that to even infertility for a Klinefelter and so on. So we have established an understanding that aneuploidy is detrimental, first for the fertility treatment and also for the health of the live birth. So if we do PGT-A, we actually avoiding genetically affected live birth, we are reducing miscarriages, and also we are decreasing the implantation failures. So what are the challenges that is facing us? The main issue was choosing which source material we should use for doing the PGT-A. We started with the polar body biopsy. Of course, it provided us with a lot of information, but this information was only limited about the maternal part. So we didn't know anything about the contribution of the sperm or the post-zygotic errors. And in this recent RCT, they showed that even if you do polar body biopsy for advanced maternal age, you will not improve the clinical outcome or the live birth rate. So what did we do? We moved for another source, which is the cleavage stage. So on day 3, we take one cell. We assume that this cell represents the embryo. And based on the outcome, we transfer the embryo. In this paper of Richard Scott, what they did is they transferred for each patient 2 embryos. One of these embryos, they did biopsy, and the other embryo, they didn't do biopsy. They didn't, for the embryo that they did biopsy, they didn't look at the PGT-A results. So the only variable between the 2 embryos is the biopsy technique. We can clearly see that when we did biopsy, we had significantly lower implantation rate. But when we applied the same on the blastocyst stage, we didn't see that difference. It means that it's safer to do the biopsy on a blastocyst stage. So we decided to look into this ourselves, and we published this paper in 2018. We compared for the same embryo doing the biopsy on day 3 and doing the biopsy on trophectoderm on day 5. And we've seen that we have almost 20% discrepancy between the results of cleavage stage compared to trophectoderm. The following year, we decided also to compare inner cell mass and trophectoderm. So we've seen that, again, we have 18 to 22% discrepancy between day 3 and day 5, whether it was the inner cell mass or the trophectoderm, while the false positive rate between inner cell mass and trophectoderm was limited to 3.5 to 4%. And the evidence is compelling. All the studies are supporting doing the biopsy on day 5. So I think we agree that for the first challenge, we should stop doing biopsy on day 3, and we should only do it on trophectoderm cells. Now, PGT-A itself, when we combine it with doing biopsy on day 5, will improve our outcomes. And these are few of many studies that have shown that doing PGT-A on day 5 will increase your outcome and even will decrease the miscarriage rate. But of course, any improvement comes with a cost. And the cost of this advancement resulted in a new term that we hear more and more nowadays, which is mosaicism. So simply, what is mosaicism? Is when you have in the same embryo 2 cell lines, 2 different genotypes for the cells. There are different options for mosaicism. It can be localized completely in the trophectoderm, inner cell mass, mixed in between. But regardless of the type of mosaicism, our responsibility or the question we're asking, what shall we do with these embryos? Shall we discard? Shall we transfer? Shall we rebiopsy? We don't know. And this was the question many studies have asked. They transferred, and you can see that there is no consensus with the results. We can see some of them reported 100%, 70%, and some only 20%. So to simplify that, let's go through 2 of the main opinions about what to do, to answer what to do with these mosaic embryos. Santiago Monet and his group compared the outcome of transferring mosaic embryos to euploid embryos. And no surprise, outcome of euploid embryos was better than mosaic. But then, as a follow-up study, what they did, they looked into the type of chromosomes affected in this mosaicism. So in this graph, when we see 0, this is the number of cells that are aneuploid, that are abnormal. 0%, it means that this embryo is considered euploid. And we can see as the percentage increases, it means that we have higher number of abnormal cells. we see that with the higher the number of cells, we have lower outcome. So you can see 78% of the cells, when they are unemployed, you have significantly lower outcome than the 20 to 29. And then they looked into further details. They stratified these embryos into two groups, one of them more than 50% abnormal, one of them less than 50% abnormal, and we can see that less than 50 is somehow doing well, not as good as the euploid, but doing partially well. So the outcome or the conclusion of this study was a priority list to which embryos we transfer. We start with the euploid embryos, then if you have a segmental, which means that only part of the chromosome is missing or is added, not the full chromosome, you go with that as a first priority, then low-level mosaic, which means less than 50% if only one chromosome, and so on. And then you have the other opinion, which says that there is nothing called biological mosaicism, or at least it's limited to 5 to 10%. What we've seen now, or what is being reported, is actually technical mosaicism. It means that we are inducing these mosaic errors. How do we do that, or how they concluded that? By doing rebiopsy, and they found actually that there is almost 36% of the embryos were actually euploid. So we were throwing away normal embryos. But what do they mean by we induce mosaicism? How do we make the embryo mosaic embryo? The best way to answer this question is by looking into this study. This is, again, Santiago Monet group. What they did is they wanted to compare between different clinics the aneuploid rate. And they chose the same population, which is the normal population, where you expect that aneuploid rate will be low. Surprisingly, the aneuploidy range between the clinic varied between 18 to 60%. It means that you had some clinics, they had 3 times more aneuploid embryos than other clinics. So how do we explain that? The only way to explain that is by all the protocols, the processes, and procedures we are doing from the moment the patient starts stimulation until we do the embryo transfer. This includes the stimulation protocol, this includes the culture conditions, the biopsy technique, the embryo transfer, the amplification, the subjective, even the subjective analysis of the geneticist. So more and more studies started to compare between the practices for biopsy. So in this study, they compared 2 methodologies for biopsy. One of them is to make the hole on day 3 and then take the cells on day 5. With the other method, you make the hole and you take the cells on day 5. They found that if you do the hole on day 3, you have significantly higher mosaic embryos. Another study, another group, with the same, comparing the same methodologies, they found the same. In addition to that, they found lower live birth rate when you do the hole on day 3. And this was the beginning of more and more studies. In these studies, they compared the pulling and flicking method. So simply, the pulling method, it depends on aspirating these cells, giving laser shots until the cells are detached. The flicking method is you aspirate and then you rub the whole thing against the biopsy pipette and you sharply cut the cells. Between these 2 methodologies, they found when you do the pulling, which is dependent on laser, you have significantly higher mosaic embryos. What about the quality of cells we sent for the lab? Have anyone seen a report from a genetic lab saying embryo number 1 is euploid and the quality of cells given for analysis was A? No. We have no clue what type of cells we are sending for analysis. So in this paper by Guzman in 2019, what they did, they divided into the cells we will send for analysis into 4 grades. Number 1 is the best, where you have more than 90% intact cells, and number 4 is the worst, where you have less than 50% intact cells. Look at the difference in euploid rate between grade 1 and grade 4. It's almost double the euploid rate when the quality of the cells was better. And you have the opposite with mosaicism rate. You have significantly higher mosaic embryos, grade 4 compared to grade 1. How do we explain that? Simply by the technique. We use laser. Laser has high temperature. The high temperature can cause necrosis for the cells. This produces material. This material can degrade DNA. And eventually, it will be displayed as if the embryo is missing these chromosomes. Not even the biopsy technique itself, maybe also the number of cells that we take. We don't know exactly the number of cells we've taken for biopsy or what we sent for that. We assume it's 5 cells, we assume it's 10 cells. And in this paper, they compared when you take 5 cells compared to 10 cells, and they found when you take higher number of cells, the genetic lab is happy because the results are better. However, your implantation is compromised. So have significantly lower implantation rate when you take higher number of cells. This is the nightmare of every embryologist because it's a huge responsibility. Everything in the lab, including the temperature, the pH, the humidity, all of these things contribute to chromosomal segregation. So if you don't have correct conditions, this will be displayed as aneuploidy. It will look as if the embryo is aneuploid, while it's the culture condition that caused this aneuploidy. So what is the solution? What do we need to do? It was nicely presented in this paper by Antonio Capalbo, where they showed that when you do more aggressive and more frequent trainings, you take care of the conditions, you follow up the outcomes with the stimulations, you have less variation and you have less rate of mosaic embryos. And they suggested these KPIs to follow. For example, less than 3 minutes biopsy, more than 90% re-expansion, 90% amplification, and so on. And perhaps what we hear nowadays about non-invasive PGT, where we use the spent culture medium as a source for genetic material, might be the solution in order to avoid all the biopsy method. Of course, it's promising. I mean, concordance rate is increasing with every study coming out recently. It's still not replaceable for the traditional trophectoderm biopsy, but I think we can get there. So in conclusion, we need to admit that day 5 biopsy is the way if we have to do PGT-A. PGT-A as a program is the best in order to increase the chances for implantation. And all these results of mosaicism and aneuploidy, we are contributing to that from stimulation until lab practices. So we need to be very careful with our biopsy. And of course, we look forward to using the non-invasive PGT. Thank you.
Thank you, Mr. Ibrahim, sir. We would like to call Dr. Nagori, sir, to hand over the memento to the Ibrahim ji.
Chirag Amin, sir, to present mementos to all the 3 chairpersons. And she is such an enthusiastic and hardworking gynecologist and inspiration for all of us. She was actually attending webinar just a few minutes back before joining us. So a workaholic lady she is. Dr. Nisarg Dharaiya. Dr. Azadeh Patel. Thank you all 3 chairpersons for chairing the sessions wonderfully. Thank you so much. Thank you.
Everyone. Now let me show you the walkthrough of our art fertility clinics, which is a state of art and having best of the facilities.
Welcome to our fertility clinics, the global leaders in reproductive medicine.
all the delegates, chairpersons, and Art Fertility Clinic for arranging this particular webinar, CME, and all the take-home messages were very much clear and practical, and this particular video will be available on AOGS YouTube channel as well for future references and for those who could not attend the CME. Thank you so much. Thank you.